All right, so we'll get started. Oh boy. Hello, everyone. My name is Laurie Lev, and I'm from the UCLA School of Nursing, and all of you met Dr. Pike and me during the first annual dental forum a few weeks back. Dr. Ramos Gomez has asked us to share some information on Dr. Pike's research area and a quality improvement project that I did recently. I always like to give the audience a little bit of an idea of how the presentation will go. So we'll have two full parts. My first part, I will be going over talking and explaining the difference between the DNP doctoral prepared nurse and the PhD prepared nurse. We thought since it could be a little bit like an alphabet soup when looking at nursing titles and letters after our names, it would be appropriate to kind of provide some clarity for all of you. Then I will present a quality improvement project I did to improve pediatric primary care providers' knowledge on and screening for non-alcoholic fatty liver in the overweight and obese pediatric population. And this really aligns nicely with mine and Dr. Pike's role in the Interprofessional Education Program, HRSA grant. As all of you know, our role is to educate our primary care, family, and pediatric nurse practitioners on ECC and caries disease management by risk assessment. And then finally, the second part is Dr. Pike will go over information in her research area on pediatric congenital heart disease and the implications in dentistry. So both PhD and DNP are considered terminal degrees for nurses, and both degrees demonstrate that the nurse is a clinical expert in his and her field. However, there are some differences between the two. The Doctor of Nursing Practice, DNP, is a clinical doctorate that prepares the graduates for advanced practice roles that can include clinical practice, leadership, health policy, quality improvements, and other areas. Whereas the PhD prepared nurse typically completes original research to obtain the degree. The main difference is that the DNP is focused more on the clinical practice, while the PhD is very research focused. The PhD nurse is expected to conduct and lead research studies and to disseminate their work via peer-reviewed publications and presentations. And most schools of nursing expect them to obtain grant funding, which supports a portion of their research salary. So the DNP prepared nurse implements the science developed by the PhD nurse. They focus heavily on the practice that is innovative and very evidence-based, which reflects the application of the credible research findings that the PhD nurse and other researchers have done. So about the certification, when attending a master's or a doctoral program, and the nursing students will choose a population foci they wish to concentrate on, and that could be in the area of adult gerontology, pediatrics, women's health, or family practice. And for the family nurse practitioner, there are two certifying bodies. The first one is the ANCC, the American Nurses Credentialing Center, and the second one is the AANP, American Academy of Nurse Practitioners. And really the main difference between these two certifying bodies is that the FNP-BC, you obtain that through the American Nursing Credentialing Center, and the FNP-C is provided by the American Academy of Nurse Practitioners. For the pediatric specialty, their certifying board is the Pediatric Nursing Certification Board, and pediatric nurse practitioners can be either certified as a certified pediatric nurse practitioner in primary care or certified pediatric nurse practitioner in acute care, or they can be certified in both. And certification is usually required with licensing as an NP, but each state has its own state board with specifics for licensing requirements. Additionally, certification indicates not only was the nurse practitioner trained in that population of interest, but is certified to practice as, in our cases, either an FNP or a PNP, where we're both certified in, Dr. Pike's certified in both areas. It's valuable not only to the nurse practitioner and their employers, but to the healthcare consumers as well. Okay, on to part two of the presentation. But first, I'd like to kind of just take a minute to provide a background that inspired this quality improvement project that I did. So in my career as an RN, I've spent several years working in the liver transplant ICU at UCLA, and I've seen firsthand the devastating effects that liver disease and liver failure can have on the body, with a huge impact on the whole person. And having a postmaster's in clinical nutrition and integrative health provided me further knowledge on the importance of treating the whole person and understanding how much lifestyle and food impacts our overall health. Now, with the declining health among our adolescents over the past 3 decades, it became very clear to me that pediatric non-alcoholic fatty liver disease is a growing public health concern that needs more awareness to change the trajectory of our children's health. So I just love this slide because it really portrays an accurate message, and that is that non-alcoholic fatty liver is asymptomatic, and it is mostly driven by lifestyle and unhealthy food, what I like to call frankenfood. And so lifestyle modifications can make a huge difference. Before I go to the quality improvement project, we'll talk about, or I'll briefly go over some background information on how we got here as a society, the prevalence, significance, pathophysiology, and risk factors around non-alcoholic fatty liver. A little bit of nomenclature. If you hear me say NAFL or NAFLD, I am referring to non-alcoholic fatty liver or non-alcoholic fatty liver disease. They're interchanged quite frequently. So my goal for this project really was to improve the awareness and the education and educate pediatric primary care providers on this rapidly rising epidemic of childhood and adolescent NAFL, because they can play a huge prominent role in screening the at-risk overweight and obese children for NAFL, mainly due to its asymptomatic nature, and without diagnosis, it really evades, without screening, it really evades diagnosis. I also wanted to improve and optimize screening practices for non-alcoholic fatty liver in the high-risk adolescent population based on guidelines, and to introduce a toolkit with usable information regarding non-alcoholic fatty liver. And then finally, integrate some supportive interventions for patients at risk for NAFL for prevention and early intervention. So it's important to go over some background, as I mentioned, information to understand how and why this condition has become so prevalent in our society. Pediatric obesity has increased substantially over the last 3 decades. It's growing worldwide alongside metabolic syndrome, diabetes, non-alcoholic fatty liver, and as well as non-alcoholic fatty liver. And according to the CDC in 2018, obesity prevalence was 18.5%, affecting 1 in 5 children and adolescents in the US, which is approximately 13.7 million children. Non-alcoholic fatty liver is one of the leading causes of liver disease in the pediatric group due to this increasing incidence of obesity. And unfortunately, over the next decade, it is predicted to be the leading cause of liver disease, progression to liver fibrosis, and indication for a transplant in our children in the Western world. Common risk factors for NAFL include the metabolic features of the obese or overweight child, Hispanic ethnicity, diets rich in foods containing trans fat and fructose, and the disruption of the gut microbiome. Over the past 3 decades, approximately 2 million additional adolescents with chronic liver disease are at risk for liver failure, cardiovascular disease, and liver cancer into their adulthood. And there's this new term referred to as obesogenic environments or conditions, and they are caused by this shift in dietary patterns, which has really resulted from an increased production of our processed foods, rapid urbanization, and lifestyle changes we're seeing in our communities. Matter of fact, questionnaires used to assess nutrition knowledge have shown that more than 2/3 of adolescents, especially overweight adolescents, have unsatisfactory knowledge about dietary recommendations, sources of nutrients, the diet-disease relationships, and dietary habits. Worldwide, non-alcoholic fatty liver in children is 10%, up to 17% in our teens, and 40 to 70% in obese children. In the US, children and adolescent NAFL prevalence is at 9.6 in the general population, 11% in our adolescents, and 50% of obese males ages 12 to 19. The Haynes data also tells us that the increase of NAFL prevalence is among both males and females and all race and ethnic groups, and confirms the highest among Mexican American obese males. There is a landmark study known as the SCALE study done back in 2006 by Schwimmer et al. And him and his colleagues took biopsies from children that had passed away in motor vehicle accidents down in San Diego. And what they found was 17.3% of children 15 to 19 had already had fatty liver infiltrates, with the highest at 38% in the obese children. Now, currently, there is no data of NAFL in California. However, we do have a significant populace at risk. California has an estimated 22.4% of Hispanic adolescents 10 to 15 who are considered obese. California, 52% of our children are Hispanic, 60.8% reside in the LA area. And in SPA 2, Service Planning Area 2, where this project was conducted, 19.8% of the children seen between 5th and 9th grade are considered obese, which is consistent with the national average, about 20.6% of 12 to 19-year-olds being obese. Now, although non-alcoholic fatty liver is seen in normal weight children, the prevalence of it in the adolescent population has been increasing in the obese group. And it is associated with multiple comorbidities, including lipid abnormalities, hypertension, obstructive sleep apnea, metabolic disorders, low bone density, psychological disorders, and hormonal disruptions, such as in polycystic ovary syndrome in our female patients. It's associated with the early onset of type 2 diabetes, and it is estimated to increase the risk of early cardiovascular disease by almost 5-fold. Long-term survival for children with NAFL are at 13.8 times the risk of dying or requiring a liver transplant compared to the unaffected general population of the same age and sex. And really, research is suggesting that adolescents with NAFL are at high risk of mortality rates as young adults, and that long-term mortality and liver transplantation requirements will continue to rise in the pediatric patient with NAFLD. And furthermore, there is no approved pharmacological therapies to date. So the impact and the significance is really concerning and serious for our future generation. What further complicates the condition are the gaps in screening, where most of these overweight and obese children are not being diagnosed or receiving the relevant or recommended evaluation or interventions. And that's because majority of the providers just do not identify NAFL as a clinically important diagnosis. They're not referring their patients to gastroenterology or hepatology. And partly because diagnostic and management approaches to the patient with NAFL are highly variable and inconsistent within the current literature and the practice guidelines. So making the true prevalence of pediatric NAFL may be even higher due to the lack of recognition, and that there's this clinical concern regarding the appropriateness of diagnosing a child with this condition alongside an underappreciation of its associated complications and an overall lack of research in this population. And including, it remains understudied and definitely underrecognized in terms of the preventable lifestyle causes. Despite screening is consistently advised in the current guidelines for children who are at risk. So a little bit about the pathophysiology of NAFL. It's characterized by 5% or more of fat accumulation in the liver, and it represents a spectrum of liver pathologies ranging from isolated steatosis to steatohepatitis to cirrhosis. However, a more recent complex understanding of the actual pathophysiology of NAFL is this dysregulation of the gut microbiome, being described as this gut-liver axis. It's a 2-hit process where the first hit is a combination of that obesity, the insulin resistance, in combination of high-calorie diets, excess fructose intake, and a genetic susceptibility. The second hit is this oxidative stress and activation of the innate immune system, where inflammatory cytokines or apokines get triggered and progress the disease, causing progression of the disease. So basically, non-alcoholic fatty liver results from this crosstalk between multiple organs, including adipose tissue, the pancreas, the gut, and the liver. But how all of these mechanisms interact together is very complex and still only partially understood to date. Genetically, fatty liver is seen in family groupings independent of the adiposity, and the severity of fatty liver among families with non-alcoholic fatty liver correlates with BMI compared to families without NAFL. There is this gene, PNPLA3, which has shown a strong relationship with the development of NAFL, and a polymorphism in this gene variant has been correlated with increased ALT levels, more frequently seen in obese children and adolescents with metabolic syndrome. And another key driver is this excess fructose consumption in our adolescents, which has been associated with the epidemics of obesity and NAFL. In particular, the Framingham Heart Study did note that regular sugar-sweetened beverage consumption was associated with a greater risk of fatty liver, particularly in the overweight and obese individuals. So what we're seeing here is this increase of fructose consumption, obesity, and NAFL all rising exponentially together, and which is a perfect example of this diet-disease relationship that I refer to. And what is happening here is that this ingestion of fructose alters the gut microbiome, increasing the movement of endotoxins into the portal system, which increases the intestinal permeability, causing changes of increased liver inflammation, and then that insulin resistance. And which, by the way, fructose is metabolized almost exclusively in the liver, whereas glucose is metabolized throughout most cells in the body. As mentioned on the previous slide, in use, there is this increasing evidence of NAFL being associated with extrahepatic disorders such as cardiovascular, diabetes, and decreased bone mineral density, renal dysfunction, obstructive sleep apnea, and hormonal changes. Although again, how all these associations in these extrahepatic disorders remains incompletely understood. But interestingly, there were two studies on obstructive sleep apnea that was associated with the presence of NASH, which is non-alcoholic steatohepatitis, in two different pediatric studies independent of BMI and standard metabolic risk factors. So the risk factors we are primarily looking at are obesity, overweight with the main features of metabolic syndrome, obstructive sleep apnea, a pan-hypopituitarism, a fourfold increased risk in the Hispanic ethnicity. Asian and white children seem to be a little bit at a higher risk as well, males at a higher risk, an excess fructose consumption, and research is suggesting a very strong family link. So the importance of screening for pediatric NAFL and the reason why this project was done is because of the growing prevalence of non-alcoholic fatty liver in our children and youth. It's the highest among Hispanic males in the Asian population. It's not just a liver problem, but it affects multiple organs. The fact that it's asymptomatic until significant liver damage has occurred. And it's predicted to be the #1 cause of liver disease, failure, and the need for transplantation in our youth over the next decade. So primary care providers can really play a huge prominent role in screening. Now, the guidelines I've been referring to are NASPGAN, is what we say in short, and it's a mouthful. It is the North American Society of Pediatric Gastroenterology, Hepatology, and Nutrition. And they offer the most comprehensive screening and follow-up recommendations specifically aimed only at children. They also cover prevention, management, and referral basis. They recommend an ALT, although it has some considerable limitations. And this is because it is universal. It's a universally available test, blood test. It's relatively inexpensive, minimally invasive, and has an acceptable sensitivity. And what is really important and emphasized in the guidelines, as well as being pointed out in the literature, is to not evaluate the ALT based on the individual laboratory reference range of normal limits. So you see here that they give the ALT based on a sex-specific upper limits of normal, girls being 22 units per liter and boys 26 units per liter, and diagnosis being 2 times the sex-specific upper limit. So 44 or greater than for girls, or 52 or greater for boys. Now, the Quality Improvement Project had a conceptual framework that guided it, and it's known as the Knowledge to Action Framework because it is commonly used for the transfer of research findings right into clinical practice. It's been adopted by organizations worldwide, and it's utilized by the World Health Organization for such programs as the integration of the knowledge to action steps in the field of maternal and perinatal health. So I included this framework in the presentation today because I thought it broadly reflects the role of the DNP nurse and how we use primary and secondary research and apply it to the clinical setting. So I just want to take a moment to discuss the diagram here and how the framework is used. And we'll go towards the center. The framework begins in the center at the top, what is known as the funnel. This is the funnel. And at the top is knowledge inquiry. And this is all the good work that our PhD researchers are doing. That, from primary research to randomized control trials, not usable at the clinical level. So that gets funneled down into what is called knowledge synthesis. We can think of knowledge synthesis as those meta-analyses or systematic reviews. That further gets funneled down into what is called knowledge tools or products. And we can think of these as more like care plans, treatment plans, guidelines, and even algorithms that are usable at the clinical level. And outside the cycle, once a problem or a gap in care gap is identified, the circle kind of outlines how that information moves through and is applied at the clinical level, hopefully for that knowledge to be sustainable. So it's a really nice framework to use for any sort of clinical project. Now onto the Quality Improvement Project. So the QI project used a single group quasi-experimental pre-intervention, post-intervention design. The setting was at an FQHC, a federally qualified health center organization that had 10 health centers delivering primary care services where 95% of the population seen are Latino. Are at risk, right? And so the clinics are strategically placed to serve families of the lower economic communities in SPA 2, of which 20% live in poverty or below the federal poverty levels. In addition, like previously mentioned, 19.8% of these children grades 5 through 9 that live in SPA 2 are obese. And so we wanted to intervene in a population that needed it the most and where we could have the most impact. We used a convenience sample consisting of 46 pediatric primary care providers that were employed at this FQHC. So it's important to understand that all of the pediatric providers were exposed to this intervention because it's the culture within the organization to provide monthly education and professional development to all their providers. So the exposure occurred either by attending this educational initiative that was presented at one of their monthly provider meetings, or through reviewing the minutes where the PowerPoint slides were included. And further, all the providers had access to the educational material and the clinical resource toolkit within their electronic health record. So really our recruitment process was geared towards getting as many pediatric providers as possible from the 46 to volunteer to participate in doing this pre-intervention, post-intervention survey to measure awareness and knowledge on the topic. We did this by sending out a pre-intervention recruitment email introducing the project through a SurveyMonkey link. And then the QI project was announced at the provider meeting prior to the presentation. I visited all the health centers to kind of rally as many providers as I could to engage and recruit them in taking the survey. And then on the day of the PowerPoint presentation of the educational initiative, the pediatric providers were given one last opportunity to take the survey manually if they had not already done it electronically. So to measure the knowledge and awareness piece of this project, a survey was utilized known as the Non-Alcoholic Fatty Liver Disease Survey for General Practitioners. It's been validated for use in primary care providers in Australia. And this tool was developed by a group of researchers comprised of hepatologists, epidemiologists, and general practitioners. The survey consists of a series of open and close-ended questions with one open-ended question. It really covers the awareness and knowledge on the pathophysiology, risk factors, screening, and routine care of non-alcoholic fatty liver. The survey consisted of 12 questions, of which 7 questions had 4 to 7 items per question for a total of 38 items on the whole survey. The responses were true, false, or unsure. Now, I obtained consent to adapt this survey for the applicability to the United States and in the pediatric population for this quality improvement project. Once the survey was the tool was adapted, it was piloted by a panel of 6 experts, colleagues of mine, Dr. Pike being one of them, either in the pediatric specialty area, family practice, or hepatology. The whole goal of piloting this adapted survey was to check the integrity of the questions, identify any missing responses, check for spelling and/or grammar errors, and assess for any difficulties, including face and content validity. So the results from that piloted survey found that the survey questions were fair, reasonable, and feasible. And it is understood that the tool was not a validated tool once it was adapted for this project. Now, to measure screening behaviors among the providers, a software system called the I2I was used to extract the number of ALT tests completed for both the pre and the post intervention, and it was extracted by the QI team at the federally qualified organization. This is a really interesting software. It tracks population health data and was developed specifically to help FQHC organizations collect real population health information to obtain governmental funding. So the sample parameters for data retrieval included the age of the child, obesity or overweight criteria, and which health center the adolescent was seen at. And it was collected for both time periods, for the pre-intervention and post-intervention, which was a January, February, March 2019, January, February, March of 2020. The only exclusion criteria we had was that if the child had an ALT drawn within the last year. Now, to summarize, because I just said a lot, we looked at 2 outcome measures. The first one was to measure awareness and knowledge of adolescent NAFL among these pediatric providers, and we did that through the survey. The second outcome measure was to look at screening rates, and we did this through that I2I software and looking at a percentage of the number of ALTs done pre and post intervention. So the actual intervention itself, to go over that briefly, is it consisted of an educational initiative, a clinical resource toolkit that was incorporated into their electronic health record system. And then I went around and monitored the usage of the toolkit, addressed any barriers, and made appropriate changes over the 12 weeks and monitored things. The educational initiative was presented only at one provider meeting. It consisted of a 15-minute PowerPoint presentation, and it included background information on definitions of NAFL, the pathophysiology, prevalence rates, those greatest at risk, the role of fructose, their clinical presentation, and the current screening guidelines by NAFSCAN. It also included a brief introduction of the resource toolkit. And then this animated picture that I showed early was shown during the presentation as a message that NAFL is really asymptomatic. And as providers, we must go looking for it. And lifestyle plays a huge role. This is a cover of the toolkit that was implemented into their EHR system, and the structure of the toolkit adopted several of the recommendations from the Agency of Healthcare Research and Quality, the AHRQ guidelines, which really is meant to support efforts in implementing evidence-based practice into primary care. As previously mentioned, this toolkit was implemented into their EHR, and it was done throughout all of the 10 FQHC health centers. It was really designed to mirror the content material presented during the educational initiative so that the providers had a familiar working clinical resource to go by. It included an algorithm from the NASPGHAN guidelines along with a direct link to the guidelines. There was also a single page handout on NAFL available in English and in Spanish so the providers can give it to their teens and their parents. And then there was also an adapted algorithm that I did from the guidelines to address an action plan specific to this local FQHC. This is the adapted algorithm that I created that really helps the providers on a stepwise on who should get screened, and then the next steps of action once they've gotten their results back of the ALT and following the NASPGHAN algorithm guidelines. So a little bit about the study participants' demographics, a convenient sample of pediatricians, pediatric nurse practitioners, and physician's assistants. There were both full-time and part-time, and there was 14 per diem providers that were included. Now, among the 46 pediatric providers, 12 of them did volunteer to participate in taking the pre and post NAFL survey. It's important to mention here, I wanted to make a point that 25 providers did participate in taking the pre-intervention survey, and we did a power of analysis to see what that number was to get a statistical significance. Turned out to be 15. So we're sitting pretty good on the pre-intervention survey. However, unfortunately, on the post survey, we did not make that. We only got 12. So to do matched pairs for our data analysis. This was probably partly due to COVID, right? Because the survey, the intervention started January 1, 2020 through March 31st, 2020. So right when the whole pandemic was really exploding. So a little bit more about the demographics. A little over 58% of them were medical doctors. A little more than 58% of them had 10 years or more in pediatrics. 75% of them were board certified in pediatrics, and full-time, part-time was split with employment status. So our first outcome measure, knowledge. A mean was calculated on the average of correct answers out of the 38 items. And we did show an improvement from the pre-intervention mean of 26.5 to the post-intervention mean of 28. However, not statistically significant, mainly because we didn't meet that power of analysis. However, definitely clinically significant, as you'll see. So we also looked at total knowledge range on the survey's pre and post intervention, and the total knowledge range on the pre-intervention ranged from 16 to 33, with the frequency spread out for the most part all over the place. So that's on the left side of your screen. You can see here that one participant got 16 correct out of the 38, one got 33 correct out of the 38 items, and it was really just kind of spread out. On the post-intervention range, we did a little worse on the lowest end. Only one got 14 correct out of the 38. We did gain one on the highest score of 34, but we did have 3 participants, a little cluster here that got 30 correct out of the 38 items for a 25%. Okay, looking at our second outcome measure, the screening portion of it. So in between the two time periods, in the 2019 time period pre-intervention, 1,205 children met the criteria to be screened. And among those 1,205, 266 actually got an ALT performed with a percentage rate of 22.1. Now, post-intervention, 837 kids met the criteria to be screened. Among the 837, 371 actually had an ALT performed with a screening rate of 44.4% with an improvement of 22.3%. So we were really happy with this, obviously a statistically significant with a p-value of 0.001. Now, I'm just going to remind you here because there is a kind of a gap here where in the pre-intervention timeframe, 1,205 kids were obese. In the intervention timeframe, only 800. Remember, this is that COVID time, and we were asking people to stay home, and they did. So that probably explains why a lower rate, but we still improved on screening rates. It's also important to note that the diagnosis of overweight and obesity became automated at the exact same time as the beginning of the quality improvement study. So this obviously influenced the providers to do something with that diagnosis. So what I mean here is that when the child's weight and height were entered into the computer, into their chart, if it met the criteria to be overweight or obese, the program automatically just gave them a diagnosis. So the providers probably, seeing that diagnosis needed to have a plan. And so drawing labs was probably part of that plan. In more robust studies, this would be considered a confounding variable that obviously influenced results, not being able to make, solid conclusions. However, this was a real-time clinical intervention, and I like to think that the two complemented each other, and in the end, hopefully improving outcomes because we did get more kids screened for this condition. We drilled down a little bit further for possible interventions later among these 10 health centers. So what you're looking here at on the screen are the 10 health centers on the way on the left. And then the number of obese and overweight children seen per clinic or per health center, and then the total number of ALTs done per health center, and then the 2020 period of the percentage that were actually screened per health center, with a total percentage of 44% compared to the 2019 time period of only 22% of the kids were screened. And so I highlight here that there were 3 health centers that had higher rates of obesity. And so looking at this, there is some further intervention that could be done at these health centers to help lower the rates of obesity and overweight in the kids they're seeing at these particular health centers. And then the only thing I wanted to point out here is that one of the health centers is a school-based clinic. And as you know, all the schools were closed down during this time period, which resulted in this negative percentage change in ALTs being performed. So we also did a quality project evaluation. We were interested in hearing what the providers thought about the project. So we sent out a SurveyMonkey link to all 46 providers to evaluate how they felt that the project went. Ironically, we received 12 responses. However, not necessarily the same 12 providers that participated in the non-alcoholic fatty liver survey. It would have been nice to have the foresight to include that question in the survey, evaluation survey, but lessons learned for next time. So to briefly go over the project evaluation, a little over 66% of the providers felt that the educational initiative on non-alcoholic fatty liver was a benefit to their practice. 50% of them felt that the project met the objectives of the project. A little over 58% of them felt that the project on adolescent non-alcoholic fatty liver changed their practice when providing care for the overweight and the obese adolescent a lot. And then 75% of them now feel they have the awareness and knowledge to recognize, screen, treat, and manage non-alcoholic fatty liver in the adolescent population a great deal. So some good success story there that we were very pleased and happy with. So the take-home message here is that it's an increasing public health issue, largely underrecognized and underdiagnosed. Further complicating it, no approved pharmacological therapies and limited management protocols. Fructose seems to play a major role in this diet-disease relationship in the development of NAFL, and unfortunately, it's not just a liver problem, but it affects multiple organs. It is asymptomatic until significant liver damage has occurred, and this is why pediatric primary care providers can play a predominant role in screening overweight and obese kids for NAFL due to the asymptomatic nature of this chronic liver disease that evades diagnosis without screening efforts, and emphasizing how much lifestyle modifications can make a huge difference. So in summary, There's mounting evidence to support the need for primary disease prevention in reducing the incidence and prevalence of non-alcoholic fatty liver disease in our pediatric population. The outcomes of this quality improvement project were positive in showing an overall clinical improvement in knowledge and a statistical increase in their screening practices. It's sustainable because now the organization has a new policy after doing this project that all providers are to screen the high-risk adolescents for non-alcoholic fatty liver. And this supports that the quality improvement project could be disseminated or similar quality improvement projects could be disseminated throughout other FQHC clinics who serve adolescents at risk for non-alcoholic fatty liver. So I wanted to make this talk a little bit more applicable to the dental perspective. So I wanted to see what was out there in terms of oral disease and the connection or association to liver disease. I did a really quick search and to see what information I could find and if what kind of research was being done. And from what I could find, the research is still in its infancy. However, I did find some information on common risk factors being between dental caries and non-alcoholic fatty liver, obesity being one of them. Matter of fact, the association of anthropometric measurements and oral health is not surprising. Obese people have a different composition of salivary bacteria, changes in concentration of sialic acid, phosphorus, and peroxidase activity, as well as reduced flow rate of stimulated saliva, which also could promote dental caries and periodontal disease. There's this positive association between obesity and dental caries in children and adolescents. However, it's not known if this reported association is because a direct relationship between obesity and dental caries or the unhealthy diet, which is a common factor between both conditions, is responsible for that association. However, preliminary findings in a recent study published at the end of 2020 suggest that levels of mutant streptococci and the presence of lactobacillus in the oral cavity, as well as the lower GI tract, were associated with early childhood caries. Moreover, obesity was found to influence this relationship. Again, not new information that an imbalance of the oral microbial flora contributes to oral and systemic disease, but there is some work out there discussing oral microbial dysbiosis has shown to contribute to gastrointestinal system diseases such as inflammatory bowel, as well as liver cirrhosis. In particular, the species are of buccal origin, suggesting an invasion of the gut from the mouth in liver cirrhosis. In 2019, Weintraub and colleagues examined a connection between the diseases in oral cavities and non-alcoholic fatty liver. And what they found is that people with any untreated caries were more likely to have non-alcoholic fatty liver. They also showed an association with non-alcoholic fatty liver and tooth loss, periodontitis, and untreated dental caries. Fatty liver and dental caries also have a strong common risk factor in the consumption of simple sugars, glucose and fructose. And furthermore, there's several hypotheses out there linking non-alcoholic fatty liver and periodontitis through this periodontal pathogen inflammatory mediator oxidative stress pathway. And then prior studies that I found have indicated that non-alcoholic fatty liver incidence increased in participants with a prior elevated periodontal clinical attachment loss. So given that non-alcoholic fatty liver's prevalence is increasing, really more research is needed in this area to better understand its interrelationship with oral health, providing more potential opportunities for the medical dental integration. And I'll just leave you with this final study occurring in Japan right now. It's an ongoing multi-center 2-arm open label prospective randomized control trial. They took 40 adults ages 20 to 85 who have known diagnosis of non-alcoholic fatty liver, as well as a documented moderate periodontitis, and they randomly assigned them to 2 groups: an intervention group where they'll receive monthly scaling and root planing, and a control group where they'll do toothbrushing as their usual care. The primary outcome that the researchers are looking at is a change in the ALT levels from baseline to 12 weeks. And then the secondary outcome will be a change in the serum IgG antibody titer P gingivalis at the 12-week mark. So it'll be interesting to see and follow these studies and see what goes on further, what they find out. These are my girls. These are my granddaughters. Lily Rose on the left was 2.5 when this picture was taken, and her big sister Blair at 5.5 when the picture was taken. And they're showing me their GMA, how they do good oral hygiene and brushing their teeth. So I hope you've enjoyed the presentation, and most importantly, I hope you learned a little bit more about non-alcoholic fatty liver disease. If you have any questions or comments, they can be reached at the email provided on this slide. And I'm going to stop sharing and turn the screen over to Dr. Pike for her presentation. Thank you.